Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I'm joined by Ajay Gupta. He is a tech innovator. Thank you so much for joining me today.
My pleasure, Rosa.
We met through a shared concern about nursing wellness and especially just the wellness of all the people working in healthcare these days. And I'm used to talking to other people who work clinically about this concern, but I was really surprised at how strongly you feel about this. Could you share with us kind of your background and what brought you into being so passionate about helping in the healthcare space?
Well, I've been in healthcare for quite some time, right? My company is a health risk analytics firm, right? So we are using, obviously, today we use a lot of artificial intelligence and machine learning models to predict health risks. The reason we do that is so that we can work with organizations, whether they're hospitals and health systems or departments of health or even companies who want to manage the risks of their employee population or even their consumers. We do that work to find ways to improve health outcomes so that, less people are sick or suffering illness, less people have missed work or missed events in their lives because of being sick or unable to participate. And then we find that one of the big challenges is right here in front of us, right? That the people who actually care for us, they themselves are suffering and harmed. And so it kind of makes all the hard work we do to anticipate risks and mitigate risk from the outside all for naught, right? If the caregivers on the inside aren't in the best shape to provide care. And then I wear another hat as a chairman of the board of a fairly large health system with hospitals and facilities across 3 states, Trinity Health Mid-Atlantic. And so we see every day that hospitals are struggling to stay afloat, to stay and have the capacity to provide care. And our own people aren't well, then how can we get the community to feel well and to recover and to heal? So I think that there's just a reality here that we have to address. And when I look at it, I see that, hey, if we can actually make our own people feel well, be better, that's going to have an impact on our patients. And if we have an impact on our patients, that's going to have an impact on the hospital. So this isn't one of the rare times when doing the morally correct thing is also right for, business outcomes as well.
Exactly. You can try to serve the bottom line without serving the people involved, but it's not a good long-term plan. You might try to balance your budget for 1 year, but then if your company goes under because everybody leaves, that's not a good long-term
Yeah.
plan, is it?
Yeah, especially in a business that is itself a social good business, right? So I don't know that focusing too much on the bottom line directly is even a short term plan. I think it feels like it could be, but this is a social good business. We have to have the long term view. We have to have everyone's best interests in heart. And I truly think that that's the only way to make this
Yeah.
business
And I
successful.
love what a big picture thinker you are. Tell us some more about HSR Health and the work that you've been able to do on a global scale.
Well, health is a global phenomenon,
Mhm.
much like the weather. To know health anywhere, you have to track health risks everywhere, much like the weather. But we really got started with HSR when we discovered a paradox in healthcare that whenever we talk about improving the quality of care, we look really for clinical interventions. Those are everything from new pharmaceuticals to new surgical procedures or devices or new medical devices. And that's always good. We always want to push the boundary of what healthcare can accomplish. But these new clinical interventions are almost universally more expensive than the interventions they replaced. So essentially we've come to a place where doing healthcare better often means doing it more expensively, which is the wrong approach when we want to reduce the costs of healthcare. So we needed to find non-clinical interventions that achieve quality improvements and quality of care increases while reducing costs. And so that requires a lot of technology. That requires the ability to predict health risks before they happen, if you will, so that you can be prepared to treat or mitigate on an individual level, on a population level, throughout. That's what we do, and our platforms, our systems, our data sets, and all of our risk indices allow for that. Allow for identifying in advance the health and medical needs of an or identified population.
That came in handy during the COVID pandemic, didn't it?
It did. We were in a way lucky. And I hesitate to say this, right, because I don't ever want to say that the pandemic was a good thing or there's something, good about it. But just before the pandemic, we were working with the USGS, actually, believe it or not, they're a big geospatial technology user in the government, and FEMA on identifying the health and medical needs of a disaster impacted population
Mhm.
prior to the disaster making landfall,
Mhm.
if it's a hurricane or a wildfire approaching an area, so that the resources needed to treat those populations could be planned in the normal course of operations and not necessarily
Yeah.
after the storm happens, which is a few days of delay. So we were already in that mindset. We were already building mechanisms for preventing and for predicting health risks. And then when the pandemic happened, well, those same tools become more important. So we literally were able to, and obviously in a state of emergency, you do this things. In normal times, we wouldn't. But we literally were almost overnight able to take the algorithms for identifying needs in wildfires or hurricanes and transform them for infectious disease spread and what kinds of resources and personnel and evacuation and strategies would be helpful in that scenario. And then we worked with health organizations around the world, WHO, PAHO in Central America and South America, to deploy our algorithms so that those organizations and those nation states could take advantage of health risk analytics in addressing and
Yeah.
responding to COVID.
That is incredible, and it's great that you were so well positioned to be able to just jump in and help when it wasn't what you could have anticipated as much as your whole work is about anticipating a crisis. Didn't see that.
We hadn't really had a pandemic of COVID level pandemic in 100 years, right? So while there were people saying that there's a rising risk of pandemics, not a lot of people were really paying attention to that, right? We hadn't had
Specific,
one; it
right?
hadn't
It wasn't
happened,
specific to any certain contagion that you could have already tracked, so
right?
yeah. So at this point, like when I went to check out the HSR Health website, it looks like you're measuring lots of different deserts. Would you like to describe some of that?
Yeah, so that's another area where we find healthcare challenges, right? That we kind of assume that the availability of care resources and facilities and hospitals and doctors is going to be uniformly distributed across the country. Because we kind of assume that for a lot of things, right? A lot of things in the retail market, which is kind of the market we see, that yeah, there's fast food places everywhere. There's a department store everywhere. There's gas stations everywhere. Maybe not at the exact spot where you are now, but you go a little distance and you'll find all those things, right? But that's
Yeah.
not actually the case. It's certainly not the case in healthcare, where there are large gaps in the country where there's one or no providers. Insurance and transportation and, the availability within a particular doctor's day for an open appointment. Those are all important things. But if there's not even any doctor or pharmacy in the area, that's a little different. That's a higher level of what we call
Mhm.
care deserts. And I was especially surprised when we talk about pharmaceuticals or pharmacy care deserts. And I say that because our pharmaceutical industry is so large in the United States, right? Where individual pharmaceuticals can have $20 billion a year in sales in an environment where not everyone has equal access to a pharmacy to get a refill or a prescription in the first place, which means even at that level, pharmaceutical companies are kind of leaving some money on the table, right? That some people are not getting a refill simply because it's too hard to get to the pharmacy, right? And of course, we have some solutions about pharmacy by mail solutions, but those are not necessarily as well known or ubiquitous as one might think, even though e-commerce is growing. So we do track deserts across the country, pharmaceutical deserts and all other service lines of healthcare, so that we can assess what the impact of that lack of access is to the populations in that inside that desert and also to those outside, because those providers who are available outside the deserts are likely feeling an extra burden or extra load, patient load, because of those gaps. And that has a cascading impact.
Yeah. When we spoke before, you talked about the importance of having a hospital and kind of building a community around that hospital because it employs people, but it guarantees a certain amount of safety for the people who live in its sphere of influence, right?
Let's primary and secondary service areas are other terms that we use to see sort of what is their of influence area. But the catchment area, those in the catchment area typically can get their care at the hospital and that kind of thing. The EMT, the EMS, emergency medical services deserts is probably one of the biggest surprises, right? Because we hear and we say all the time, call 911. So there's an assumption that it's everywhere. but it is not. And it's not just that because in some places, for one reason or another, it's slow. There's some places where there is no EMS service, right? And then, especially outside of Philadelphia, for example, many hospitals who were doing the EMS, right? The hospitals in the Philadelphia area perform some of the EMS service themselves. They close. And so that service goes away. And yes, there is the attempt for those healthcare organizations that survive to try to pick up the slack. But they can't do that, right? They're not designed to serve all of the areas of their own plus other neighboring hospitals, right? So there are areas in America, and not even only in just rural areas, that just simply don't have adequate EMT coverage, EMS coverage. So that's a surprise, a shock, and it's something that from the local to the federal level, we kind of have
Yeah.
to come to terms
And I
with.
wonder how much of that has to do with the fact that they don't have the same kind of quality monitoring that we do in other areas of healthcare. Because emergency medical services is under the Department of Transportation. They're not even under the Department of like Health and Human Services. So, and a lot of them are staffed by volunteers. And so it's really interesting to me the way it is such an enormous part of our systems of care. Like if someone's having a heart attack or a stroke, which is what I see a lot of the time, you want to get that care as fast as possible, but it might take 2 hours for the nearest ambulance.
It
Or
might.
if it's staffed by volunteers, they might be farmers out in the field, got to come in out of the field to respond to this and then get in their truck, right?
It's possible. I mean, I'm sure that all across the country, we have a large country and a lot of different communities that run it, that EMS services are managed differently. A lot of times, though, they're high quality when they get on site. They do
Yeah,
want to do a good job, and they volunteer because they really care passionately about the work, about serving their community. So I think it's just a matter of resource level, right? What level of resource do we think we should make available at the local level to provide service to our neighbors, our friends, relatives, neighbors, should they need it, a health emergency, right? For a long time, we haven't really had that conversation, that sort of national conversation. I think we're going to do it now. We're going to need to do it now because the conversation at the federal level is about how we are going to reduce spend and reduce costs of healthcare. Right. In fact, that's the only conversation in healthcare is how much and how do we reduce spend. Right. And so if we reduce spend, that's fine, except what are you saying about what level of service we want to provide? The service that we provide is going to have a cost. It's not going to be free. EMS in a lot of places are volunteers, but that doesn't mean the
exactly.
service is free, right? So there are costs to it. Who and how are we going to bear it? As a society, we get to have that conversation and decide now what do we want to do.
Yeah. And you were talking about how we could identify these areas in the deserts that would be the most strategic places to place new hospitals or position these
Yeah.
pharmacies.
In fact, I was in a conversation once with a state secretary of health. I won't mention the state or the secretary, but presenting this care desert, right? And we were saying that this care desert is based on, I believe it was a 45-minute drive time analysis, right? So the secretary asked, "Is that the right drive time for access to care?" And I didn't, paused because I didn't want to sound tongue in cheek because it isn't. When I said to the secretary, well, that's a decision you get to make, right? It's your state, you're the secretary of health. You get to decide what you feel is the safe, adequate, acceptable time it takes for a person in your state, your constituent, to drive for care. If you want that to be 30 minutes, then these analysis will shift. But if you think that for some services or for some conditions, an hour drive for care is sufficient, the analysis will shift to accommodate your view of health for the state. And so now we get to make that decision as a nation, right? And this is something that we need to think about. And again, I go back to this is still fairly an uncommon phenomenon. Most people just assume that we have these resources. Healthcare is so big in America, we say 20% of GDP. Of course, it has to be everywhere, right? How do you get that value if there are places where you can't contribute to the spend, right? So the fact that there's lots of places where we don't have it at all, I'm sure comes as a shock to a lot of people. And now we get to decide what do we want to do about that. Just accept it and, maybe change how we live our lives in those areas, move. What do we do? What do we do based on the availability or lack of
Yeah.
availability of
And there's
healthcare.
so many elements to prevention of the need for that healthcare. Anything from their food sources, so identifying food deserts, how far does someone have to go to obtain food? Because even in rural areas, people are not necessarily subsistence farming and feeding themselves off of their own
Yeah.
land. They may not know how to do that and have access to that. And there's some farmers who get paid not to farm, right? Because there's not enough water. So there's also the primary care availability and whether or not it's sufficient to have a physician within a certain number of miles or if nurse practitioner coverage is adequate for that area. And there's a lot we can do with prevention that is outside of a hospital that can prevent those higher acute care costs from being needed.
Yeah. Well, yes, I think we've known that all the time, right? There's a famous saying goes something like an ounce of prevention is worth a pound of treatment or
Yeah.
something like that, right? It's an old adage. And it's true. The more you can prevent, the less you have to treat, right? The more you can prevent, not only the less you have to treat, but the less you kind of have to screen for, right? So there's a lot of costs that are saved when you do prevention. Now, prevention does not have to
Right.
be very expensive at all. Now, you're mentioning food, eat well, get moderate exercise, get some exposure to direct sunlight, not too much, but some, and monitor your sleep. You do these four basic things, you're probably going to be on the upper end of health for the course of your life. Now, that doesn't mean you won't be into a, unlikely, unusual car accident. It doesn't mean that you won't have an unexpected cancer diagnosis, but it does mean on average, you'll probably be a little bit healthier than your peer group. And therefore, you'll probably cost a little
Yeah.
less to the
If your
system.
cardiovascular health is good, that says so much for the whole rest of your body. So, those simple things that we know, but we can't always make it happen. It's not always easy to do these very simple things.
Well, yeah, I think I'm sure that's true, right? I'm sure that these simple things are not actually as simple as we think they are. But I also think that is that what people's interests are, right? So there's is the simple thing actually simple? That's one, right? Is the simple thing actually do we know how to do it, right? Can we agree on what the right amount of exercise and sunlight and sleep and a healthy diet are? And then do we have incentives to do it, right? I mean, if we have insurance from an employer or something and we just pay a copay and we don't see the true cost of all of the systems we use, what's the incentive for the person to be healthy? And then are we interested in it? Right. So these things that we do that are less healthy, maybe we choose not to eat the healthy option, even if there was a healthy food store right next door to the place we went for a meal. Is that because we wanted that unhealthy but savory meal?
The
A lot of
cost of
times
fast food
people
has gone up so much, you might as well choose the healthier option because they're both pretty equally expensive at this point. There did used to be a discrepancy there, but I think we've kind of closed that gap. Seems like it here anyway.
Yeah, that stuff works, right? When you start making cigarettes more expensive, of course, less people do buy. I mean, sales do go down.
Well, this brings us to the $1 billion question. We're talking about money. Yeah.
$1 billion
So if
question.
you,
Yes.
Ajay, were given a grant for $1 billion to meet the needs that you're seeing in healthcare, how would you like to see it used strategically to have the most sustainable impact?
I like how you asked the question, how would you use $1 billion strategically in healthcare? Because we know you cannot solve healthcare with $1 billion. Healthcare is one of those few industries where $1 billion is probably not enough for the industry, right? But that said, if I had $1 billion grant, I would actually invest that money in clinician wellness programs for clinical staffs and nursing staffs all across the country. Because I do think that, and I say this with full knowledge as we sort of started this conversation, that there's a lot of strain on the clinical staff, physicians, nurses, techs, everyone. There's under a lot of strain, under a lot of pressure. Currently, it is an industry with a very high level of not just turnover, but retirements, early retirements. And it's an industry with a high suicide rate. It is an industry that has, I think 75% of the workplace violence happens in hospitals and against clinicians. So there's a lot of things wrong with the industry. And yet we ask those individuals to do hard things to care for patients to make them better, right? Move them on a regular basis if they're for some reason can't move themselves out of bed or out of a position. It's not an easy job. So if we can make that clinical team in a better state of mind. We can say health and wellness, but just take away some of the negativity, then they will automatically do a better job. And that isn't to say that they're not doing a great or not trying to do a great job now. But as you know, if you're not at the top of your game physically, emotionally, mentally, it will come into the quality of your work output. Not intentionally, but it will do that. We know that, and we know that to be a fact. So if we can have programs that help the clinical and the workplace be a better workplace, then I am confident that quality of care will go up, which means all of the things that we use to measure quality of care in a hospital will improve. Lower falls, less infections, less medication errors, all of those types of things will improve, less readmissions. And when those statistics that we measure hospitals against improve, hospitals make more money, right? Either fines go down or happy populations, happy patients, have more philanthropic support of those institutions. Those hospitals will do better. So this is really a way where I actually think if we actually spent $1 billion nationwide, we would probably gain more than $1 billion in increased revenues, increased financial stability to all of the hospitals where such a program takes place.
Agree. If you don't have to train new staff to replace people, there's a lot of savings right there in cutting down on turnover, isn't there?
Statistics suggest that it's n- nearly $60,000 per nursing turnover, which is somehow an astronomical number that I think more people need to come to terms with that. That cost alone would justify doing what you can do to try to keep your nursing staff together along. What I will say though, when clinicians thrive, patients, hospitals, and we all win.
It is a team sport after all. And the truth is, like, as much as nurses should probably get paid more, doctors should get paid more, you cannot pay people enough to care as much as they already do. They're already not in it for the money or they wouldn't be there. Like,
Right.
healthcare, there's a lot of money in healthcare, but it's not going to the direct care providers on average.
Yeah.
And so I really appreciate your emphasis on just their mental and emotional well being because you're right, it does get passed directly on to each other, to our patients, to the community. Like how we feel is contagious to other people. So
Right.
I really I think you're
That's
onto
right.
something there. Have you seen anything that's been effective in your health system where you're in leadership that you think you'd like to see duplicated anywhere else?
We are doing a number of things, and we have a virtual nursing program that has seemed to help a great deal. And what that is essentially it's not yet fully deployed throughout the system.
Mhm.
It's in the process. But we have a virtual nurse that's a seasoned senior nurse who is not there at the bedside or in the ward on the floor. They're watching a number of patients through two-way high definition screens, and they have access to the clinical team on site. So they can see the patient as they need to. They can communicate with the clinical team on site. And so it gives the clinical team on site, they know they have somebody supporting them. They have a senior, skilled, experienced nurse supporting them, watching them, helping them with something they may not know, something they may have missed, organizing and helping them prioritize the patient care tasks, right? So the clinical team really loves having this virtual nurse. The patients love it too because they can hit a button and know that that nurse is
Yeah,
there right away. We've all experienced, the nurses are busy, you're in the hospital room, you buzz for the nurse, and it takes some time for the nurse to come. But this is not that case. The virtual nurse is there. She's watching all of the patients or have the ability to watch all the patients. So you hit that, the patient hits that call button, nurse pops right up. Patients love that. That alone, nurse hasn't done anything yet, right? They've just popped up on the screen. They're ready to talk. But just that access alone, patients feel better right away. So it seems to help everybody out. And it also, we're getting the sense that it is extending the career of these senior nurses. Some of them, not all of them, but some of them may have been ready to make a decision to retire from bedside nursing. This gives them the ability to stay close to nursing and
mhm.
to mentor potentially younger nurses who are still at the bedside and help everyone, progress in their careers. This is a win-win scenario at our health system. But that's not to say that that's the only thing we should do. I mean, we should always be looking at innovative ways that we can make the hospital experience better.
I agree. And not just like this is how we've always been doing it. And if we have to have change, it means trying new things. Maybe that works there. And if it works there, you can put it in another place as well. And you can try
Yeah.
another new idea and see if you can continually
Right.
augment it by trying new processes.
I'm glad you said that. I don't think healthcare gives itself enough credit for trying new things. I mean, we're always changing, maybe not today, but we're always changing how we
Hmm.
treat patients, right? I mean, it's famous now that we used leeches in the past when somebody was sick, right? That was state of the art medical care. We don't do that now because we change. We learned and grow. We learn and grow on a very regular basis. So this fact that, hey, we are always doing the things that's not really from our industry. That's something else. We change. We change when we see evidence to suggest there's a different, better way to
Yeah.
treat a patient.
And some people have said that they think nurses are resistant to change because we might seen some new technology brought in and have a negative first reaction to it. But a lot of that might be because we're so accustomed to having to find a new workaround for the new technology that was created without asking the end user how they actually would need it to function. And so it's like this ingrained that you think that we have to get trained on this one time in this hour training on using this new pump. But we also anticipate having to figure out in real time when someone's having a crisis, oh, there's an actual problem in this, and I have to figure out how to, on the fly, fix it as well. And just not being able to trust that things have made it to that point being put in a effective way.
Yeah.
And so I think nurses
Yep.
are great innovators and very open to change and new ideas. We're just tired of having to clean up after situations like that.
So, Rosa, Steve Jobs was famously quoted as saying that he doesn't ask the consumer what they want because the consumer doesn't know what he can do, right? And so I say to that, to your point, look, if you're going to design a medical device or a nursing tool without asking the nurses, you better be as brilliant as Steve Jobs. If you're not, maybe go talk to a few nurses, see what they need, see what
Yeah.
they want.
Or at least just be part of the process and do plenty of testing before rolling it out, maybe. So
Yeah.
I really appreciate your valuing of humanity. You're definitely one of the cool data nerds, I think.
Sounds like an oxymoron.
I don't know. It's the nerds that rule the world now, isn't it? So, well, I really
Cool.
appreciate you taking the time to your
My
insights on the
pleasure.
podcast. And if anyone wants to learn more about HSR Health or contact you, is LinkedIn the best way?
LinkedIn is a good way. Yes, LinkedIn is a great way. It's a convenient way to connect. You can certainly check out our website, hsr.health. Not .com, it's hsr.health because we are a health firm. But yeah, LinkedIn is a great way to connect.
I will have
Right.
your links in the show notes as well for anyone who would like to just click on it and not have to do a lot of typing. So if you are
Thank you.
listening to this and you enjoyed it, please leave a comment wherever you're listening. Please like and subscribe if you're listening or watching on YouTube. And let me know if you know of someone else who has a great idea about how we can make the future of healthcare better. And I'll see you in the next episode.
Thank you,
Thanks.
Rosa. It's a lot of fun.